All right. Again, hey y'all, it's Rachel. We're doing hip anatomy today, which is pretty exciting. Um, just so you guys know, if you're watching this like later on and you're looking at the slides have barely anything on them because everything we do today is gonna be on complete anatomy. So just watch this video for reference instead of slides this week. Okay, so let's just start with the basics. The hip is kind of confusing, but if we're going to break it down, it comes down to three different bones, which is the sacrum, the coccyx, and the rest of the hip bones. The rest of the hip bones are basically divided into three separate bones, which is the ilium over here, the big boy, and then we have the pubis and the ischium. These three bones are actually separate, even though they kind of look fused here. And inside, like deep inside this acetabulum is where they all connect. And yeah, they just connect there. So things you have to know for hip anatomy are parts of these bones, surfaces, and landmarks. And we're going to go through each one today. So starting with the parts of the hip, it's pretty simple. Basically, there's like two or three parts of each separate bone. So for the ilium, we have the body and the ala. Ala means wing, and it's just this big fossa area, whereas the body is down here. And this connects to the ischium body over here, and the ischial ramus. Ramus basically means arm. So think of it as like a human butterfly with like the body here, the arm outstretched, and a big wing over here. And for the pubis, we have three parts. We have the body, again, the main area, and then we have two rami, the superior and the inferior ramus. And that's basically it. Just everything has a body and a ramus of some kind. Next, for the surfaces of these bones, starting with the ilium, we have the iliac fossa. Fossa basically means hole. So this is like the concave area within the ala of the ilium. And next to it, we have the iliac crest at the top. The iliac crest is basically the highest like level of the hip bone, and the tip of it is situated in L4, which is important because that's the same level where the aorta bifurcates. It's a landmark for lumbar punctures and so forth. So remember, L4 is the top of the hip. Next, as we move down, oh, where is it? Okay, next we have the pubic crest and the pubic symphysis, which is over here. The symphysis of the pubis is basically the area where like the left and the right pubis connect, and it's kind of like a joint of some kind with like a fibrocartilaginous disc in between that basically just holds your pelvis together so it doesn't explode. And the pubic crest is the area just lateral to it with this little bumpy bump. And that's basically it for surfaces. Landmarks. Now, landmarks in anatomy basically mean areas where they're like protrusions where different muscles or ligaments attach or move through to the bone. And we'll just start off with the acetabulum over here, which is the hole where the femoral head basically rotates in. So there's two parts of the acetabulum. First of all, we have the fossa, which is like the hole deep inside. And then we have the lunate surface, which is the wall of the joint. And just remember, this is the area where the three hip bones connect, as you can kind of see here. Excuse me. Okay, and now moving up to the ilium. First, we have the anterior superior iliac spine, or ASIS, and inferior to that, we have the inferior version, which is the AIIS. These are basically areas where different, like for example, the inguinal ligament connects here, or just random ligaments and muscles connect. And as we move up, we have one more on the anterior surface, which is the iliac tubercle. This is just situated upon the iliac crest, and it's basically the bumpiest part of it over here, and I think it attaches the iliotibial tract. Like if you're a runner, you've probably heard of like ITB syndrome, where the iliotibial tract is inflamed, that basically attaches here. And then moving back to the posterior side of the pelvis, so looking at it from behind, we have the PSIS and the PIIS, basically the ACEs, but behind. The PSIS is like the most superior bump here. And on some patients, you can call it like the dimples of Venus. Have you heard of that? Like on your back where you have two like little dimples right above your gluteal area. And that's the area, sorry, that's the level of the sacroiliac joint as well, like the sacrum and where the sacrum and the iliac connect here. And where the top was L4, this is at the level of S2, which is worth remembering. And then over here we have the PIIS, which connects sacrotuberous ligament, I think. Just a lot of different ligaments that hold all these bones together. Next, what should we do next? All right, moving down from that, we have the third protrusion on the posterior surface, which is the ischial spine. Now this ischial spine can be kind of hard to find, but it's basically the area that separates the greater and the lesser sciatic notch, which are these, well, they'll look like holes once you add all the ligaments and stuff in. But yeah, this just separates the top hole from the bottom hole. And what the ischial spine is attached to is, which ligament was it? Sacrospinous ligament, sorry. And the sacrospinous ligament, as we'll see later, just comes across here and forms these two holes. And next we have the ischial tuberosity, finally. And this is basically your seat bones. So whatever you feel like you're sitting on right now, it's this little guy, the most posterior area of the pelvis, and a lot of different muscles attached here, like your hamstrings attached here. So as we'll talk about later, you, in a lot of like athletes, if they run too fast or they just damage the hamstring muscles, it can tear off a piece of this tuberosity. But we'll get to that later. Cool, so that's all the landmarks you guys basically need to know. There's plenty more that you can probably find in diagrams, but honestly, this is all I think that's important. So let's move on to the holes and the openings of the pelvis. Starting with, let's get the muscles up here. Okay, starting with the obturator foramen, which is this big boy here, and the only one that really looks like a hole. So the obturator foramen is this big hole, and inside it we have the obturator canal right here. And you guys will definitely learn this, and it's pretty important because it's where the obturator nerve, obturator artery, and obturator vein all move through here. And they course all the way from the pelvis to go to the areas of the inner leg, down here, or like the gluteal region behind. Issues can happen here when there's like neuropathy, when stuff is compressed. Again, we'll get to clinical later. Next, let's go to the back, and we can see the greater and lesser sciatic foramen, as we just mentioned. So remember here, we have got the iliac tubercle. No, ischial spine. Sorry, there's so many names. And over here, we have got the separation between the superior and the inferior sciatic foramen, which is the sacrospinous ligament. So the greater sciatic foramen, which is this hole right here, it's basically home to the piriformis muscle, which moves through before attaching here to the greater trochanter of the femur. And as well as the piriformis muscle, we have here the sciatic nerve, which moves through. And the sciatic nerve comes from various branches from the sacral plexus that comes from the spinal cord over here. So this sciatic nerve, it's really big. Like once you guys get into dissection next year, you'll see that the sciatic nerve is actually like a centimeter long. You won't believe it's a nerve, but it's huge. It runs down the leg, innervates most of the muscles down there, and passes through the greater sciatic foramen. As well as that, there are plenty of branches, as you can guess. For example, this guy, pretty important, superior gluteal nerve, basically innervates the superior gluteal muscles at the back. But again, we'll get onto that later. Also, it has the pudendal nerve. I think there are 7 nerves overall if you want to learn them, but just remember, sciatic nerve moves through there. And aside from nerves, we have 3 vessel sets that go through there. So the superior gluteal nerve and vein, the inferior gluteal nerve and vein, and the, artery and vein, I mean, and the internal pudendal nerve and vein. Artery and vein. So yeah, it's a bit of a mess, but 3 vessel sets, 7 nerves, piriformis muscle. Just remember that. Okay, now let's move down to the lesser sciatic foramen. Oh, I turn all this off. Okay, the lesser sciatic foramen is inferior to the sacrospinous ligament, and it's this little ovular hole over here. And what passes through here is, you can remember a good acronym, which is PINTO, P-I-N-T-O, the pudendal nerve, internal pudendal artery and vein, nerve to the obturator internus, and tendon to the obturator internus. And basically, it's just pudendal and friends. So as you can see here, we've got the pudendal canal, which is like this little cylindrical canal that moves through here. So the vessels go all the way through here, down, 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 into the perineal area, which is like the very bottom of the pelvic area. You'll learn this in year 2, where a lot of the repro stuff happens. But yeah, pudendal canal, we also call it the Alcock's canal, internal pudendal nerve, artery, and vein, and supplies the perineum. That's all you need to know. Okay, so that's it for the connective tissue, bones and stuff. But finally, we're going to quickly touch upon the muscles of the hip. Oh, she thick. Okay, so the muscles, we have 2 classes. We have superficial muscles and we have deep muscles, as in everything. The superficial muscles, closer to the surface, are basically in charge of abduction and extension. So moving your leg like away from your body and extending your hip. Whereas the really deep muscles are used for like the intrinsic rotating of the hip joint. So you can rotate your leg. The arterial supply to the muscles of the gluteal region are basically the superior and inferior gluteal artery that come from the internal iliac artery, which comes from the aorta. So for the superficial muscles, we've got the triplets, we've got the gluteus maximus, the gluteus medius, and underneath it, the gluteus minimus. Now, the gluteus maximus is supplied by the inferior gluteal nerve because it is more inferior than the other 2, whereas the medius and the minimus are supplied by the inferior gluteal. As well, we have the tensor fascia lata, which we'll get out here. Okay, don't know why I wasn't on that diagram, but here the tensor fascia lata is just part of the the tensor fascia latae muscle is part of the tensor fascia lata, which is like deep fascia that goes over all the leg muscles, and it's coming from the ASIS, and it's just a small muscle that tightens the fascia lata and helps the helps the fascia lata do its job, basically. Okay, can we go back? Maybe. All right. So superficial muscles, a recap: gluteus maximus, medius, minimus, and the tensor fascia lata. Superior gluteal nerve supplies everything apart from the maximus, which is supplied by the inferior gluteal nerve. Okay, now for the deep muscles. These guys are underneath all the gluteal muscles, and they're a lot smaller, and their job is to basically laterally rotate the leg and stabilize the hip. And you can tell that because basically all of them connect to the trochanters of the femur over here, showing how they can like pull this out and kind of rotate your femur. So first of all, we have, moving from superior to inferior, the piriformis muscle, supplied by the nerve to the piriformis. We can use this muscle to locate the sciatic nerve, which moves through it, and also a lot of the structures of the superior sciatic, of the greater sciatic notch. Next, we have the, where is it? Obturator internus over here, which basically covers the obturator foramen, as you can see, and kind of makes way for the obturator canal. Little guy over there, connecting to the greater trochanter of the femur again, and easily this is also supplied by the nerve to the obturator internus. Next, we're going to move up a bit and find the superior gemellus and the inferior gemellus. And these basically have the exact same role of rotation, and while the superior gemellus is supplied by the nerve to the OI, the inferior gemellus is supplied by the nerve to the quadratus femoris, which is the final muscle here. So recap, 5 muscles: piriformis, OI, superior inferior gemellus, and the quadratus femoris. This one's piriformis is supplied to it by its own nerve, OI has its own nerve, QF also has its own nerve, while the 2 gemelli muscles are basically just use the nerves of whatever muscle is next to it, if that makes sense. So that's all the muscles of the hip. So we basically covered everything now, except for the arterial supply. And for arterial supply, we're not going to do it today because there's quite a lot to it, but on our YouTube channel, we just uploaded a video about all the nerves, all the arteries of the lower limb. So check that out. We're going to look at some clinical stuff. So these are this week's slides. I'm not going to go over it because you can just read it yourself. Probably look over hip joint ligaments. This is pretty important, but we won't go over it now. Oh, and the inguinal ligament too. This is important. But we are going to move on to hip clinical cases. So it can be a bit confusing in year 1 to know exactly which clinical pathologies are relevant. So I've just included 6 or 7 that I think you guys should definitely learn. So let's start off with hip dislocations. Probably the most common one you'll talk about. So what happens here is basically, as you can see here, the femur is forced out of the acetabulum. And moving posteriorly, it's a lot more common than anterior dislocations. And that's because the posterior area of the hip capsule is where the ligaments and muscles are the weakest, which if you look at the previous slides to do with the hip joint, you'll see why. Oh no, there's a picture right here. Great. Posterior, only this one little ligament, whereas anterior is more better reinforced. Basically, just remember posterior dislocation is common, and often the sciatic nerve is commonly affected because it traverses through this area. And for clinical, a patient with a hip dislocation will often present with one leg being shorter and turned outwards or inwards, depending on what kind of dislocation they have, and that's telltale sign of a hip dislocation. So have a look over here of how to determine it in an exam. You can test by testing true leg. I'm not sure if you guys have done this clinical yet, but you can test the true leg length, apparent leg length, and which is basically like you measure the leg, and also the Thomas test to see if the acetabulum is displaced. Okay, second of all, we have osteoarthritis of the hip, which is very common. And I think what's most important here is to remember the 4 radiographic features of any arthritis, like anywhere in the body, which came along so much for us when we did imaging last year. And the 4 things you need to know are bony protrusions, joint space is narrowed, black pits of fluid everywhere, and the bone looks lighter, like more white, as in because it's thickened. So as you can see here, this is a normal joint space. You can see there's some space between here, but over here, or even here, there's barely any darkness, barely any space between the 2 bones. You can also see bony spurs coming out over here. Over here is another pretty clear one. And the subchondral cyst, the black pits of fluid, they kind of just look like this. It's a bit hard to tell, but just remember those 4 points, which is going to be very important. So for osteoarthritis, if patients can't control it at home with medication anymore and the pain is just too bad, we do a hip replacement. There's 2 types of hip replacement. Basically, one of them is you get rid of both the acetabulum and the femoral head, or you just get rid of the femoral head, basically. In the partial hip replacement, the socket just remains as it is, whereas in a total hip replacement, we get rid of the socket, and then we put like a little capsule for the new metal head to rotate in. Next is the pelvic fracture, which is less common, but seen a lot more in motor vehicle accidents, high trauma incidents, and stuff like that. There's basically 2 types of pelvic fractures, the minor one and the major one, basically, stable and unstable. When you have a stable pelvic fracture, since the pelvis is kind of like a ring, you only have one break somewhere in that ring. And often the bone just stays there nicely and doesn't move around too much. And it happens a lot in older patients who may have osteoporosis, so the bones are more prone to fracture if they just have a little fall or something. Unfortunately, they'll just have to kind of manage that for the rest of their life, though. There's no, it just requires chronic management. The unstable pelvic fracture, on the other hand, is where in the ring there are 2 breaks, and the breaks don't exactly line up all of the time. And this usually happens with severe trauma incidents, and patients will require surgery to fix this issue usually. But again, pelvic fracture, not really that common compared to things like osteoarthritis or hip dislocations. Now, this is what we were kind of talking about earlier, about avulsion fractures of the ischial tuberosity, which is your seat bones. So yeah, basically if your muscles here, the semitendinosus, semimembranous, your hamstring muscles basically are flexed and extended too quickly, they're so strong that it basically rips off a part of your hip. And it happens more often in athletes, and this can also cause a lot of hamstring issues where the muscles are broken as well as the ischial tuberosity. And you can just have a lot of internal bleeding, hematoma, not a fun time. Okay, femoral hernias and inguinal hernias. These are really, really high yield, which we still do in year 2. But a hernia is basically when a part of your small intestine or large intestine, but usually small intestine, pushes out of like the membrane that it's kept within and pushes out, so you can feel a bulge somewhere in your body. And the places where it pushes out is usually one of the canals that we talked about. For example, the inguinal canal. Or it can just push through the muscles if your abdominal muscles are really weak, and then you have this bulge around your groin area. So for a femoral hernia, we didn't cover this, but there is a femoral canal, which you can see in previous slides, and it's right underneath the inguinal ligament, and sometimes intestine can push through here. And this is usually presents as a small lump, which is below and lateral to the pubic tubercle over here. And these are usually asymptomatic, and often patients don't even feel the pain, but sometimes they can become emergencies if the intestine starts twisting, and we call that strangulation because all the blood is cut off. And yeah, there's a lot of pain. Causes and risk factors. Men have this a lot. Men giving, not men giving birth, but men lifting heavy objects, women giving birth, especially if you're overweight and weak abdo muscles, all of that. If you strain like and you really sneeze really big, apparently it can happen, like part of your intestine just pushes out, so that's not fun. So that's a femoral hernia through the femoral canal over here, but an inguinal hernia is through the inguinal canal, which like the femoral canal is more, inferior, whereas the inguinal canal is right across here at the inguinal ligament. So there's two types. There's direct and indirect, and I literally just remember it by this meme. Direct inguinal hernias push directly through the abdominal wall without going through any kind of canal or hole and just protrude out like that, whereas indirect inguinal hernias go through the inguinal ring. There's two rings, like there's the one, like a cylinder has like two sides, right? There's a deep inguinal ring and a superficial inguinal ring, where the neurovasculature pushes through, and often in the deep inguinal ring, the intestines can actually push through there and cause a hernia. But yeah, just remember direct inguinal hernia, not through the canal. So usually when you have really weak abdomen muscles, it's easy for the intestines to just push through there directly through the body wall. Whereas indirect is when they go through the canal. And sometimes that happens because some people are born with an inguinal canal that's not completely closed if they're born prematurely. You can usually pick that up just in a baby. So yep, that's all. Hopefully that was pretty good for you guys.
Okay, cool. So I'll be taking you through Pop Health today. So as much as you will hate to hear it, Pop Health comes back year after year to haunt you. So you might as well like strap in and understand it now, because it will come back. And I think in third year and fourth year and beyond, it continues, and they make you like learn the same things every year. So yeah, learn it now. Okay, so I'll be taking you through everything up till study design. So like from week 1 to like week 5 content, and then we'll do the next half like in one go in like week 8-ish. So yeah, stay tuned for that. So definitions of what actually pop health is. So epidemiology is a study of the distribution and determinants of health and disease in populations. So essentially when you like have ICL and you're like, oh yeah, I'm in charge of epi, you're basically just looking at like who gets this disease, how many people in the population are affected by this disease, like what the risk factors are for getting this disease. So that's basically what like epidemiology like encapsulates. And then you have a definition for health, which is the WHO definition. Now, let me just check the chat. I don't know if there's. Okay, cool. Yep, all good. Yep. So it's basically just the state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And this comes up in like memes. So if you see this, you can kind of remember it just by like health being this like really whack definition that's like super like holistic and big overview of like a person. Okay, so causation. So you have two different types of like causation. You have like a sufficient cause and a necessary cause. So they pretty much just, so a lot of pop health is like, it pretty much just means what it says. So when something is sufficient, the having that is sufficient to cause the disease. Wow, what a mind-blowing fact. And then necessary means it's necessary to cause the disease. So then if you like kind of put that into context of like a disease, like an exposure and then an outcome, if you have TB, like the bacteria, you know that the disease tuberculosis requires you to have the TB bacteria to have TB, because that's how it's defined. So it means that TB is a necessary cause for TB, but you can be exposed to the bacteria and not end up with TB if you like it just don't inhale like the bacteria particles, or if it doesn't like do anything to you, you just resistant to it. So then that would mean that it's not a sufficient cause, because being exposed to it doesn't necessarily guarantee that you will get it. Whereas with the chromosome 21, you would both need it, and having it by itself is sufficient to cause Down syndrome. Okay, so there's just a couple of different types of risk factors. You've got like predisposing, enabling, precipitating, reinforcing, pretty much just what they say. This isn't that important. I think we just have them here for like the purpose of like completion. Yeah, that's, no, go back, please. Okay, definitions of risk. So these are like a bunch of equations that you unfortunately will have to remember, but something that was really helpful to help me wrap my head around this was when we had a revision lecture last year. It was absolutely incredible, and it's essentially just look at the word and think about like what that means. So when you have like relative risk, you're thinking about the risk relative between if this person had been exposed and if this person hadn't been. So then therefore you can kind of figure out that this ratio is one where you divide the risk and exposed over the risk and unexposed. So the risk that is higher, let's say if you're exposed to like smoking and then your risk of lung cancer is higher, that number divided by like if you hadn't been exposed to that thing will give you the relative risk. So then you can also, so you just think about, so it's really just like really thinking about like what the words mean and like what you're trying to solve and then relating that to the equation. So you have attributable risk as well, which is when you have risk in exposed minus the risk in unexposed. So instead of like a ratio, it's a difference. And then you have attributable fraction. So you just turn the attributable risk into a fraction. So given that the difference between exposed and unexposed risk, you divide that by the risk in exposed and then just multiply it by 100%. And you've also got population attributable risk. So this is, instead of like having cases that are attributed to the exposure, you're thinking about the entire population instead, and taking the risk in the total population minus the risk in unexposed, as opposed to taking the risk in exposed only. You're really gonna have to like really think on it, because it does make more sense once you see it in the context of like a calculation as well. And we're gonna come to that in the next slide. So with the percentage, then you're then looking at the percentage of cases in the population that could have been prevented if nobody was exposed to the exposure. So it's the attributable risk to the exposure itself in the population, and that's pretty much just what it says here as well. Okay, so an example for how this works. So you have, so let's say we have a table that has smoker, non-smoker, and like total people in the population that are at risk. So you would then look at the risk in exposed over the risk in unexposed to figure out the risk ratio. So you'd have 120 divided by 10. So that's just like the ratio between if you had been exposed to this thing and if you hadn't. Then you have a risk difference, which is just this minus this, and it gives you 110. And then you look at the fraction. So like, how does this number compare to the risk in the people that were exposed? So then you can kind of figure out what percentage of cases can be attributed to the fact that this person's gone and been exposed to this thing. Population attributable risk. So then you look at the total population risk instead of the risk in exposed, and then you minus that, so that gives you 20. And then you do some funky math here, basically just plug in the formula, and then that gives you 67%. So this is the percentage of cases that could have been prevented if nobody in the population had smoked. Okay, Bradford Hill criteria. So I'm hoping that the equation thing sort of makes sense, but I think the best thing to do if you don't really understand it is to like sit down and go through the equation and like do it yourself. Come back to like find like a couple, I think the Pop Health quizzes have a couple of different like examples of these calculations. Just like sit down and like write them out, figure out like what number comes from where, and like how you want to reason through that. Okay, Bradford Hill criteria is basically just a list of things that the thing that you're saying has an association needs to satisfy. So you have an outcome and an exposure, and to link them together, they need to like match up and meet these criteria. So the most important one is basically just temporality. Does the cause precede the effect? So you can kind of understand that if the cause does not come before the effect, you can't say that the cause led to the effect, because that's just not how time works. So when they ask anything, just know that temporality is the one that you need to have. Because with the other ones, it's like, is the strength of the association between the cause and effect? It's like, yeah, whatever. It's good if it's there, but it's not as important as actually establishing that relationship with like cause preceding the effect. That should say cause, not clause. That's my bad. And yeah, I think these are not too bad to remember, just because they basically say what they are. Like consistency, is it consistent with what's been done in the past? Reversibility, if you remove the cause, can you decrease the outcome? Yeah. Okay. So incidence and prevalence. So they do like to talk about this as well. So incidence is essentially just the number of new cases in a given period. So once you see anything in the question that has like a time period, you can sort of reason that it's incidence. And we've got a little way to remember it, new and incidence. So the N comes pretty far in the front of the word, and then it's new. So there's new cases. So because you're measuring new cases only, it's good for like acute things or things that have like that aren't present in the population for a very long time. So either they like go away really quickly or you die really quickly. Yep. And this can also be called the attack rate. And the population size, so this is something that really threw me off because of the Pop Health quizzes, because they always say like, oh, at the start of like this 4-year period where you're like looking at new cases, the population is like 500. At the end of it, it's 550. Like, what are you measuring? It's actually incidence, because even though it's a specific population, I think as long as you define like how the population changes, or you continue to make sure that this specific population is defined within your study, it's fine. So yeah, if you see that in the quiz, it's incidence. As long as there's like a time associated, it's incidence. So prevalence would be existing cases at a given time. So as you can see with the given time, it's like one point in time. You just go in and you look at the numbers. Therefore, you don't have like a time associated with it. It's like an example of that would be like, you look at 1,000 people and then 600 of them have osteoarthritis. It's just, bam, you've done it just one time. And because it's, you're doing it like in one point in time, it's good for measuring things that have like a really long period. So like chronic conditions, like you're gonna have them for years on end. Okay, measures of health. So mortality, basically just number of deaths in a population per unit time. Case fatality, these are pretty okay to remember, I think. Just if you have a case, how many people die. Morbidity, measure of people that are living with the disease. And because it's not like a measure of like death, it's a measure of like how it compares to what you would have been if you were like healthy. So you can measure this by a couple of ways. You've got years of life that you have lost. So that like compares it to like the average, like how, like, what's it called? How long you can live for. I feel like there's a better way to phrase that. You've got quality adjusted life years. So I think this is like how it compares to like so disability and quality adjusted life years I think are fairly similar, but they just view it in like a different way. One is like more positive, one is more negative. So yeah, disability adjusted is just like the years of life that you've lost because you have this condition. And then person years is just the measure of time at risk for people that have contributed to the study. And it's important to remember here that person years is at risk. Once you have the disease, you don't count in person years anymore. And if you're not at risk, you also don't count. So equations that sort of measure this burden listed here. So yeah, there are so many equations, and you should have to sit down and learn them. Incidence rate, so because we've talked about it being like number of like new events, we quote it as like number of events over total person years. And this is usually given as like a per 100 person years, just so the number isn't like super small. We've got relative risk again, so essentially just the exposed over non-exposed, pretty similar to what we had before. Cumulative incidence is just like looking at the incidence rate, but I think you look at it from like multiple times and you like add them together, something funky like that. But essentially it's pretty similar to incidence, right, in terms of like number of events over a number of people. And then you have the average duration, which is just like how long is this person going to live with this disease. And then case fatality is just if you have the cases, how many people die, and among the people that do have this condition. Okay, so we're gonna go through another example just to like put it into context. So I think this might have been one that they showed you in class, but we're just gonna run through it again, just because this is a pretty good example of how to do this calculation. I don't think it comes up that often in exams, but I don't know. Surely they have shown it to us for a reason. So I'm just gonna put it here. Essentially, you look at so when you have person time at risk, you're going to be looking at like how long the person was healthy for, because that's the total amount of time they were at risk and didn't have the disease. So they've like kindly put like the number here for like how many years this person has gone at risk. And if you add it together, you get 44.5. And then you have 4 incidences in total. So 4 people have actually developed the disease. It's like this dark blue here. And you divide the new events divided by person time at risk, which gives you like a 9 cases per 100 person years. And then you can also do cumulative incidence. So you look at like a certain time frame and figure out like what you look at like the entire everybody that participated to see like which proportion of people have developed the disease. So you can make an estimate because you have lost to follow up. That's LTFU. So if you were to assume that people that were lost don't develop the disease, you can make like a lower estimate and have like 4 out of 10. So let's say, so that you've got the 4 cases and divided by 10, so that's 40%. But you can also make a maximum estimate, assuming people that are lost have developed the disease. So that you've got the people that have lost, there's like 3 of them, I think. So 3 plus 4 is 7, and 7 divided by 10 is 70%. Because it's like a time frame thing, you can also just look at like the first 2 years. Let's say you were to look at the first 2 years. You would see that we haven't lost anyone to follow up here, and there's only one person that has developed the disease. So then you would do that math. It'd be 1 over 10 is 10%. This is also in the epidemiology textbook if you do want to read up on it, although I don't think it's that important. Okay, exposure and dose effect / response. So you have different types of exposure. you've got something like you can have like acute exposure. So let's say you're exposed to COVID-19 and then you get COVID. And then you have like accumulation. So this would be something like if you smoke for many years, then you increase your risk of like lung cancer. And then you have dose effect, which is an increase in exposure leads to an increase in symptoms for one person. And then you can kind of like generalize that to like onto like the population level with dose response. So if you increase the dose, you increase the number of people that have this condition. And then something that I don't think they teach, but they like, it just happens to appear in like quizzes and stuff. So we just have it here, but essentially you've got different types of sampling, you can do it different ways. And I think they all have like different benefits and stuff to like why you would choose that. Probably not gonna go too much into detail because it's a bit dry. Okay, types of data. This is fairly important to know, and I think this kind of builds on from like middle school knowledge. But you've got two types of data, you've got categorical and numerical. Nominal, just order doesn't matter, so blood type A, B, C. There's no C. A, B, and O. That's a yikes for me, dog. And then ordinal, you have like categories that mean that where you order them does matter. So BMI categories, it'd be like underweight, normal, like overweight, obese. And it wouldn't really make sense to like jumble up that order. Whereas with blood type, you could jumble up the order and it would make sense still. Okay, and then numerical is just like number stuff. So then you have either continuous or discrete. Continuous would just be like something like height. You can have like 160.3, you can have 160.356. Like it's continuous. You can keep going on the curve. And with integers like discrete, that would be like something like number of children, because you can't have like 0.5 a child. It's always going to be like one step up. So 1, 2, 3, etc., etc. Okay, so types of error. So we've got a different couple that are listed here. So we've got random error. So this is just stuff that's due to chance. It might just be due to like just stuff that's like, life happens. Things go wrong. And so this can be reduced by increasing your sample size so that the things that go wrong will overall when you average it out, it's reduced. And because you can go wrong in either direction, if you have half of them going wrong and like the measurement's too big and half of them is like measurement's too small, then it sort of like evens out as well. You've got biological variation, which is just because people are different. And then you have systematic error, which is like when something is systemically too high or too low, or like it's skewed in one direction. Whereas with random, it's like both directions. So this can be caused by like a measurement bias. So for an example, like if you were reading like the thermometer, like the ones with mercury, if you read it from like an angle that's not right, or like if you read it from like consistently too high, the way you see like where that mercury level in comparison to the markings will be it'll be wrong, and it'll be wrong in the same direction every time if you read it from too high every time. So that would lead to like systematic error. Yes. You can also have selection bias, which would also lead to this kind of thing, because when you're selecting people for the study, it may be possible that you're selecting people with like a similar characteristic, which would skew your measurements in like a certain direction. And you've also got recall bias, which we'll talk about a little bit more in the context of like different study designs. So people that have a disease are probably more likely to recall like what they've been exposed to than people that don't have a disease, just because of like that's kind of how your brain works. Like if you have like diarrhea, you're shitting yourself, you're probably gonna like be able to better remember what you ate in the last day than someone that doesn't have diarrhea, because it's like not that important to them. Okay, and then you've got sample size. It's just if your sample size is too small, you're going to have error, and that relates to like the random error as well. And lastly, confounding. They love to talk about confounding. It's basically where between your exposure and your disease, you have another factor that actually links the two together. So the exposure and disease don't actually have a relationship. It's just because you have this third factor that contributes to both. So you have a link between blue hair rinse and hip fractures only because age is a confounder. So if you had age here, old people are more likely to use blue hair rinse, but they also are more likely to have hip fractures. So then you can sort of see that age is the thing that links the two together, rather than blue hair rinse leading to hip fractures, because there really isn't, like, it doesn't make sense for there to really be like a relationship. And you can also understand that there's potential for this to happen in pretty much all studies except for random controlled trials, because you are assigning the exposures. So then your two groups of people, the people that are exposed and people that are not exposed, they would be pretty much identical except for the exposure. And so then you could reduce the effect of confounders. So we've got some more things about confounding. So in terms of trying to control for it, because it is such a big issue, you can do things at different stages. So within the design stage, you can, randomize, which is what we talked about with the randomized control trial. You can restrict it to only certain traits. So let's say like you're going to look at people that don't smoke only, so that you can make sure that smoking is not going to be a confounding factor. And you can also do matching. So in a case control where you're looking at, when you're looking at people that have the case and don't have the case, you want to make sure that all of the other exposures that you're looking at are like, that all the other traits are going to be the same, just so that you don't have one factor that's only affecting one group and therefore would be able to act as a confounder. And then you have things that you can do at the analysis stage. So you can stratify your tables. Essentially just means that you have one table with all your like data in it, and then you have another factor that you suspect may be a confounder. So you split your one table into two tables, with one table being like with this confounding thing and one without the confounding thing. And you can compare the values to see if like the confounder is actually the thing making the difference or leading to this like outcome that you've just calculated. And you can also do statistical modeling, which is a very vague, floaty term, but I suppose it's there. Okay, so evaluating the quality of research, you want to look at two things. This is also fairly important. I think it might have come up for us. So validity essentially measures, does the test do what it's intended to do? So is it either, so it has to somewhat satisfy like internal and external validity. So with internal, is it valid among the people that you are studying? So it's, internal to the study itself. And external would be, is it generalizable to like other people? So that's external to the study, also fairly self-explanatory. And reliability is just whether you can repeat that and get the same results over time. So stability, getting consistent answers, and then reproducibility. If you just like threw this at a different set of researchers, could they reproduce this with like a different population? Okay, types of testing. So you've got diagnostic and screening. So essentially, diagnostic is you're trying to diagnose a condition. So they have presented with symptoms and you're trying to figure out like what's going on. With screening, they don't have symptoms and you're just doing it like on a blanket. You're just screening everyone just to see if there's like anything there. So it's important to note that tests can be both, depending on like what situation they're using, and the way these are defined is dependent on like where the patient is in terms of whether they have or don't have symptoms. So if someone like came in for like a breast screening, if they had like a breast lump and you were like doing imaging for that, that would be diagnostic because they have symptoms. Whereas if they came in, if this same patient came out without anything, like no breast lump at all, and you were just imaging their breast, that would be screening because you're just like, trying to see if there's anything funky going on. Okay, so super high yield study types. These are things you should definitely know. And this comes back. There's like every assignment ever is going to be talking about like fucking study types. Oh, I might have put a question. Sorry, person time. So it's essentially just like the time, the definition that we've been given is like the time that you are at risk for. So one person year is like, it's literally just like a normal year, but because you have many people in a study, you have to like find a way to add them together. So hopefully that sort of makes sense. If not, Google it or check the textbook for it, because I'm sure they'll explain it better than I can. Okay, so overview of study types. You've got a whole heap of studies, and then you've got this triangle that basically shows, oh, I've got another chat, just closed it, my bad. Okay, cool. Okay, so essentially just, it's like the evidence pyramid. So the stuff at the top is the best, and the stuff at the bottom is the worst. And they're categorized into like observational and experimental studies. So observational is basically you just like sit there and look at like what's happening. Whereas with experimental, you're actually assigning the exposures. So that's also why it's a little bit better in terms of like evidence. Okay, we're gonna go through this from the bottom up. So ideas, editorials, opinions. These are trash. You don't really look at them. It's just like someone's like, oh, I think vaccines cause autism. I mean, I think that one was like supposed to be a proper study, but it's, it's that sort of idea. It's literally just like an opinion. Someone's like, oh, I think this does this, and they haven't done any research into it, or it's like it's pretty meh. And then you have case series and case reports, which is just like descriptions written by doctors or like a team of doctors. And it can either be just like one patient or like a bunch of different patients together. And so an example for this would just be like, oh my god, there's more typos. My bad. Pneumonia in like young homosexual males with like an unknown disease. So then that would have like formed the basis for doing some more research into like what they had. And I think that, you know, that would have led to the discovery. Well, I don't think that directly led to the discovery of like HIV, but it would have been like, we should probably look into this. Okay, so some good things about this is that it can identify like potential health problems. So like that's what you've seen with the HIV example. And also if someone else is like, oh yeah, I've noticed something similar, maybe you can, I think that would potentially lead to like further studies because, you know, it's something that's been observed universally. So bad things is just that it's not really that much evidence. It's like, sure you're like writing about stuff, but you're not really comparing anything. And there isn't a lot of, because it's usually not that many patients either. It's not super great. Okay, next one is ecological studies. So you're comparing the exposures and outcomes in a population, on a population level. So let's say you're like comparing things from different states. So each state would like be their own like little population. So this kind of helps you link exposures and outcomes, and they really like this keyword like generate hypothesis from ecological studies. But the thing is, you can't really like establish causation with an ecological study because you're taking this information from like one point in time. So essentially people that drink the alcohol may not be the ones getting the liver disease, and you also don't know that the cause comes before the effect. And of course you can get confounding again. Okay, the next one is a cross-sectional study. So this is sort of similar to an ecological, except for that it's not done between populations. You're just looking at like one defined population, and you're looking at data and exposure and disease at the same time. So then you can sort of, because you're looking at like exposures and disease, when you look at disease at that one point in time, you're measuring the prevalence of it. And again, you have the same issue of like, you don't know if the exposure or the effect came first. And yeah, cool. So case control, we're getting like higher up the pyramid, which is nice. So case control is your study looks at people that have the disease and people that don't have the disease. So you start off with the cases, and you can see it here as well. And you can kind of remember that with the word case control. So because the first word of the study is case, you look at cases first, and then you ask about previous exposures that they've had, and the outcome of this table that you end up creating is reported as an odds ratio. So because you're starting with the cases, one thing that's really good about this is that you can use it for really rare diseases. So things that you wouldn't, because you would choose people that have this disease in particular to look into and ask questions about. And because you're starting off with cases, you can look at many different exposures and you can ask them about a lot of stuff. However, the thing that's hard about this is because you have one group that's like cases, you know, it's pretty clear who you're choosing. It's kind of hard to figure out like who you're going to be choosing for the controls to make sure that you're cutting out like as many confounding things as you can. And recall bias is also pretty real in this one because you're asking about things that they've been exposed to in the past. And people that have a disease are probably going to be more likely to remember that rather than the people that don't have the disease. Okay, cohort study. So this is very similar to your randomized control trial, which we'll talk about in a bit, but you don't assign the exposures. So you follow your participants forward in time and you check to see if the exposure that they're already exposed to will lead to different outcomes. And the end result is reported as a relative risk or risk ratio. So this is probably one of the best ones for causation among the observational studies. So it's an experimental because you're not actually like interfering with anything. And this is carried out if it wouldn't be like ethical to conduct a randomized control trial. Let's say like there's a huge difference between the like treatment and like not treating. And because you're looking at exposures, you can look at you can focus your study to look at people with a specific exposure that may be potentially quite rare. So that's good. So it's really good for rare exposures. And because you're starting off with exposures, you can look at multiple outcomes and you can evaluate many of those. And one bad thing is just that because it's over a long period of time, you're going to lose people over time, and it's really only for common diseases, just because you don't know who's going to develop what disease over time. Okay, Stella's also provided a really good explanation. Thank you. Okay, so retrospective. So one funky thing about cohort studies is you can sort of go backwards as well. So the direction of inquiry is backwards, but your study still goes forwards in time, and it's kind of hard to wrap your head around that. So essentially, you have a record of people that have past exposures. So let's say people that like have been in the army, so you know what they've been exposed to. And once you've established the exposures, you follow these people forward in time to see like what they ended up developing, and you look at their like current health. So it's, although you're using past records, you're still following them forward in time. So it's very similar to like the perspective, except for you've already got like that period of time that you otherwise would have needed to wait for. If that makes any sense. And you've got some like other small observational studies that are like amalgamations of like a case control and a cohort. I don't feel like it's worth really learning these because like genuinely spent so long reading this, trying to wrap my head around it, and like I don't know, I highly don't know what's happening here. So if you really want to learn it, go read the like Webb and Bain epidemiology textbook, but I don't think it's that important to know, and it's pretty niche. Like I can't think of like a situation where you really want to use this. Okay, and then we're getting to like the good stuff, randomized controlled trials. So you as a researcher assign the participants exposures, and this is like always listed as like the gold standard of like epidemiology. So in terms of making sure that the process of like assigning exposures is like really solid, you go with things called like random allocation and allocation concealment, which allows for the two groups to be as similar as possible. And this is something else that helps you to prevent confounding. So random allocation just essentially is you allocate exposure or not exposure at random. You don't know who's going to receive what. And allocation concealment, I think, is where the participant doesn't know whether they've received the exposure or if they haven't. And that also prevents like it from like being like a placebo effect. And then you also blind. You can like single blind, double blind, or triple blind. Oh, there was a really good meme about it. I should put it in. Oh well. There's blinding that essentially the people that are involved don't know what's happening. Like if they don't know if the participant's exposed or not. And the one thing that is quite unfortunate with this one is that because it's like a big scale, like you're assigning or you're not assigning, it might not be ethical or practical to really perform this on like a big scale. So although that one's like the spiciest like experimental study and you get like hella good evidence from it, you can go even further and you can do a systematic review which looks at like all of these randomized control trials and then forms a conclusion based on all of these trials that have been done. And this one is like really absolutely mint just because you're combining like the results from all of these studies that are already pretty high quality, and then you average it to like form like a final like big conclusion. So some math that I think they threw into the slides at the end of the study design stuff was like intention to treat versus completed therapy. The examples that they have are pretty good. So if you want to like run through your own calculation, just go through that. But essentially the difference between the two is that when you're analyzing intention to treat, you compare, oh, why is there a typo in this as well? You compare the groups as they were originally assigned, regardless of whether people actually received the intervention or not. So it means that you're reducing like the biases that might arise from taking into account like people that dropped out, just because it might be that everyone that dropped out for like a similar reason, like if they were assigned the exposure and like life sucked, so they were like, all right, I'm gonna peace out. That would impact your like final calculation. And you've also got completed therapy, which like doesn't take that into account, and it's just based on who completes the study. So you can kind of see that this one would be more biased, although I guess you could do both. But I think what faculty likes to say is that intention to treat is a little bit better. Okay, so we'll have some questions now. That was a lot of epi just thrown at you. Okay, so use of old college alumni records in the US to study benefits of physical activity as a young adult. Just check some answers up. Yeah, that's it. Retrospective cohort study. Well, yeah, essentially it's just because you're using past records that are pretty comprehensive. It's just retrospective just because you already have those records. Okay, next one. So it's good for rare diseases and the outcome is reported as an odds ratio. Yep, so you're starting with cases, and therefore you can look at specific diseases. So yeah, that's correct. Love your work. And so this is about the Bradford Hill criteria. Yep, cool, cool, cool. Yep, so once you have a time period, you know it's incidence. Okay. Oh, it gets drier and drier. We're going to do some bacterial pathogenesis now. All right. Let me know if you want me to like explain this in depth, because I'll probably just like sort of summarize it. Like everything's on the slides. Okay. So definitions: a pathogen is something that's capable of causing disease. The process by which it does that is called pathogenesis. The ability of an organism to cause disease is like its virulence factors, and the factors expressed by the organism that allow it to do so is the virulence factors. So these are just some basic definitions that will help you understand what the heck is going on. Also, apparently this meme is approved by the microbiome lecturer. I had a friend send it to her, so yep. Okay, so some virulence factors that aid in adhesion include pili or fembri, and it's this one I think this one came up in like Sem 1. It's just like the hairy things that stick out, and they help to like mediate a bunch of stuff because they funky. And then you've also got like non-fimbrial adhesion, so this allows for it to stick without the use of fembri, and it's just got these proteins that like sticks onto like the host. So examples of that would be like bordetella or like staph. Staph does literally everything. if you see staph, it's probably staph. One thing that I've structured these slides, all of the like bacteria pathogens are in like blue, and they're the ones that the lecturer talked about. So potentially examinable. Who knows? Microbiome just be like that. Okay, so capsule, this one was talked about in Sem 1 as well. It's just like you've got this like sugary layer around your bacteria, and it helps to stick to things. So things that have that would be like strep pneumoniae, strep pyogenes, Neisseria meningitis. And the three adhesion factors lead to the formation of biofilms. So that's essentially just like a big like layer around things that make it so that it's really hard for the immune system to like get through and like clear this layer and clear the bacteria causing it. Okay, so things that lead to and so that help the pathogen with invasion. So this is I think one of the high yield things from microbiome, because I remember this coming up in the exam and I was like, bro, what the heck? Okay, so collagenase and okay, let's start from the start. So your bacteria can express a number of enzymes that help it invade the body. So you have collagenase and hyaluronidase, fucking hard to pronounce. And this basically degrades your extracellular matrix to get deeper. You've got coagulase and streptokinase, which like messes with your blood to hide from the immune system. So you can like hide within clots and then come out after that to like continue spreading. You've got urease, which neutralizes your stomach acid, which is like, you know, very acidic, and it's supposed to be an acidic environment to like prevent things from being there. And it makes like a little cloud that by cleaving urea, and it allows for the bacteria to approach like the mucosal cells and damage it. So an example of this is H. pylori, which causes like gastric ulcers. You've got IgA protease, essentially just it cleaves the IgA in your mucosa, and then DNase. So when your neutrophils try to do things, they like explode into like a trap in attempts to keep the bacteria in one place, the pathogen in one place. And when it expresses DNase, it can just swim out and after degrading that trap. And you've also got things like degrade complement, and we talked about complement last semester with immunology, and it just makes it so that the complement can't do what it needs to do. Okay, so examples of effective bacteria. So these are examples that they like talk about fairly extensively. So I'd say like the effective ones you probably should sort of know about. So Listeria, it basically goes into the cell, and then it sequesters all your actin, and it creates a little like tail to move between the cells and escapes immune detection because it never really has to leave the cell. It just travels between. And then you have staph that like literally just does everything. So phagocytosis, I don't know if this was covered last sem, but I'll just sort of go through it briefly. So you've got your phagocyte that like engulfs the thing, puts it in a vesicle, and then it has another vesicle full of like bad stuff, the lysosome, and then it combines the two and allows for the bad stuff in the lysosome to kill the thing it just ingested. And it does so by having like a really low pH, having a bunch of enzymes, having like free radicals, reactive compounds. So in efforts to avoid death by phagocytosis, which is like a pretty big way our body gets rid of like bad things, it either has a capsule that to avoid contact, so it just has a bunch of stuff around it. Let's say like your sugar capsule. It just looks like your body just goes, oh, that's just sugar, it's fine. And it prevents the phagocyte from like detecting that it's the bad and then eating it. You've got toxin release. So if your bacteria like spits out a toxin and the toxin's bad for the phagocyte, your phagocyte will get killed. If you don't have opsonization, which is just when your antibody like sticks to it and is like, hey, look at this bacteria here, come eat it. If you don't have that, then there's no signaling saying let's eat this thing. And if you inhibit your phagolysosome fusion, so if you don't let the lysosome, which is full of the bad stuff, fuse with the phagosome, then you're not going to be able to kill the bacteria like via the process of phagocytosis. And it does this by like injecting things into like the phagocyte before it gets eaten up. And so some examples of things that do that. Okay, so an example of one that does this quite well is that Legionella. So it never allows the lysosome to fuse, and it does so by like the mechanism we just talked about. So it injects a bunch of stuff into the cell, which makes it so that the lysosome doesn't like mature properly and doesn't fuse with the phagosome. So I think the keyword here is like type 3/4 secretion. I don't know why I highlighted it, but I remember it like coming up. So yeah, if I can remember anything, I guess remember that. And so 3/4 are important as virulence factors, and it acts with ATP to actually like pump in these proteins that affect the lysosome. So because phagocytes naturally are out and about to eat things, it also needs ways to get into cells that don't naturally tend to eat things. So these are your non-phagocytic cells. So there are two main mechanisms for this. You've got the zipper mechanism, which is basically just like your bacteria comes onto the thing, and then like the membrane of the cell like curves around and encloses it sort of like a zipper, which is why it's called the zipper mechanism. And then you've got the trigger mechanism, which again uses a syringe. So you punch a hole into like the host cell and you inject some funky stuff, and then the host cell's like, oh yeah, I guess I'll take this thing in now. So example of something that can do this is Shigella. So it uses the trigger mechanism, which is just like punching the hole to like inject some stuff, and then it infects like non-phagocytic cells to annoy the immune system. And it also is able to use an actin tail, similar to what we had seen earlier. And once it does that, it can just move between cells and doesn't really have to leave the body or leave the cells to like be exposed to the body environment with more immune cells. So endotoxins are like components. So when you see endo, it's like part of like the cell itself, or like part of the bacteria itself. And these are basically just another word for like lipopolysaccharides. So you can sort of see it here. It's just a component of the like the gram-negative cell outer membrane, and the active component is lipid A. So yeah, that's pretty much what endotoxin is. And that's significant because it can lead to different types of shock. So we'll just go through a couple definitions, because I think this is like fairly, it's just like good to know like what each of these words means. So sepsis is when you have like a whole body systemic inflammatory response, and it can be caused by anything. Like it can be gram-negative, gram-positive, virus, fungus. Hypertension is just low blood pressure. And when you have septic shock, it's the combination of the two. So you have sepsis-induced hypertension, and that's just your body's like responding in such a way that like you got like hella vascular permeability, your liquids are whack, they're not in your blood vessels, they just chilling. And then you have endotoxic shock, which is a particular type of septic shock, which is induced by gram-negative bacteria, which is what we just talked about, because they have that component in their outer membrane. So endotoxic shock is the bad, because you can have, you know, immune storm that is in the body, and you have just everything is kind of going crazy. And because of all of that, you have a bunch of symptoms that you can get. Just your immune system is literally going crazy. You have like fever, shock, you're like inflamed, everything's just like not in where it's supposed to be. And some examples of this would just be like your gram negatives. So these are the bad. And yeah. Okay, so once we've talked about endotoxins, it's also worth talking about exotoxins, which is ones that like toxins that are like secreted by the bacteria. So this would be something that gram positives can use, because they don't have that natural like endotoxin layer, endotoxin component to like the cell membrane. So you've got super antigens, which basically just activate your T cells directly. So they just like approach your T cells, they're like, all right, you're activated. And because of that, that leads to like a huge cytokine release. And then that further activates your T cells. And because everything is now activated, you got like huge immune response and things are not good. And so Staph aureus can do this. And an example of that would be like toxic shock syndrome, which is like on every like tampon packaging ever. And it releases a super antigen, which leads to this huge like immune response. So you've got toxins that can act at this target cell surface. So phospholipase, literally just what it says, it is an enzyme for the phospholipids of the cell wall. And then you've got pore-forming cell lysins, which is just, you've got protein bits from the exotoxin that combine and then punch a hole through the lipid bilayer. And that leads to the explosion of the host cell. Okay, and then you've also got toxins that modify intracellular targets. So I think this is one of the more important exotoxins you should probably know because this one does come up. So these toxins always have like an A-B structure. So they have the two components that work together to cause this effect. So examples of this, and these are important, surprisingly. So diphtheria is a simple A-B toxin, and it leads to like that dead necrotic tissue in the throat. And you've got cholera, which is a compound A-B toxin, so AB5. And so it's taken in and then it changes like your camp levels, which leads to like a really funky electrolyte imbalance. I think your chloride leaves the cell, which leads to water leaving with it. And then you end up with a super like rice water kind of like stools. And then you've got some neurotoxins. So these act at like the neuromuscular junction. And if you have like botulinum blocks your ACH release, which means that your muscles can't contract because that's needed for that contraction movement. And you've got tetanus, which blocks the release of inhibitor neurotransmitters, which mean that once you've sent out the signal to contract, there's nothing there to stop it from contracting. So you have like spasms because you're continuously contracting. Okay, that was a lot of microbiome. Come back to the slides if you want to read through anything or just want some notes. But we're going to go through some questions now. Okay, so Staph aureus uses coagulase and streptokinase. What does this entail? Yep, cool. That's right. Clotting, dissolving of blood. I think this might have been like one of our exam questions. Okay, and then what is true about Legionella? Like, how does it work? Yep. So it's got that ability to punch a hole into the thing to secrete stuff into it. And then cholera. I think this might have been adapted from like a Moodle quiz or something. It's really mean. Okay, I'm just gonna. Does anyone want to throw an answer in? Give it a shot. Okay, so cholera is a complex one. So it's the one that leads to like the rice water stools, and yeah, it's just mean. It do be like that. It acts within the cell. It's an AB5 toxin, and it leads to an increase in CAMP levels, which like messes with your electrolyte balance of the cell. Okay, yep, that's pretty much it for microbiome. I'm glad you guys got through that. Let me know if you have any questions. Big session today.